invite Dr. VASAVADA, who is going to talk to us in his most favorite talk on posterior polar cataract. How to manage these cases effectively so that we come out with all the difficulties can be taken care of on the table. Dr. Abhay, please.
Thank you. This is my financial interest, but has no relevance in this presentation. And I just want to make sure that we understand the posterior polar cataract. This is a kind of a posterior polar cataract which late Dr. Daljit Singh described as onion appearance and bullseye and whatever. It is distinctly different from posterior subcapsular plaque cataract. So you need to make sure it is a posterior polar. And I recognize the contribution of Dr. Osher, and it's a great pleasure to recognize Professor Jeevan Tithyal's and Manpreet Kaur's contribution on the subject in recent years on various aspects of diagnosing and dealing with this posterior polar cataract. I think if I have to number one pearl, I would say avoid the hydraulic rupture of this thin, fragile capsule, and that happens because the fluid is trapped in that critical compartment. So avoid the rapid buildup of the hydraulic pressure and therefore hydraulic rupture, and it's common sense that you will not do this cortico-cleaving hydrodissection or subcapsular hydrodissection. Second thing, it will be prudent to create a protective cushion effect to that fragile capsule, and if you can do that, it's not 100% necessity, but it's a good idea, and I recommend that. But mind you, the conventional hydrodissection has served the purpose very well, but sometimes there can be inadvertent fluid seepage into subcapsular plane and therefore hydrorupture. So to make sure that doesn't happen, we, with the help of Dr. Shetal Raj and other colleagues, developed a technique what we named inside-out delineation, where the fluid is injected in the wall of the core of the material of the lens, and therefore chances of subcapsular hydrorupture will be less. This is the clinical example. Create a space, and a typical posterior polar, it's very soft cataract in a patient of 30s and 40s, and it's very easy to produce this demarcation and appropriate depth of mechanical cushion effect. Third is to adhere to the principles of closed chamber technique, and therefore anything you do should not make this capsule diaphragm bulge forward. And therefore, when you exit the instrument out of the eye, inject OVD. I prefer viscoat, a dispersive viscoelastic, but whatever. Make sure that the contours are maintained. And this is very important, that when you have removed the nucleus, now you have an epinucleus, and you have two compartments, one in front of the epinucleus, anterior chamber, and one behind that critical space. So you detach the epinucleus a little bit, and the idea is to create the communication now between the posterior critical space behind the epinucleus and the posterior capsule and anterior chamber. So the fluid seeps in, and then the fluid is not trapped there, and there is, now you can do subcapsular hydrodissection if you want to into the subincisional area for thicker epinucleus. So create a communication between these two compartments. And femtodelineation, and I saw femto being used in dense cataract, but Jeevan Tithyal would vow that femtodelineation or any other techniques of flex really makes it more controlled procedure, and there are various ways of using this technology. And in our hands, we reported 32% at one time, then reduced to 8% with inside out, and now it is about 4% with this flex technique. And that's because the cushion effect is created well and no need to rotate. So there are, I recognize Professor Tithyal's presentation here with Manpreet here, but this is what we typically do. I don't want to go in details, but you can shell out these, I'm not able to handle this here, but you can bring out those demarcated, femto-demarcated fragments to the tip, and then make it very easy and user-friendly to the I'm not able to move this forward for some reasons. That's okay. And then when it comes to the subincisional, the same procedure, shelling out, and it is so easy because it's laser cut, very sharp division, and it's very easy without rotation. Keep the phacoprobe right in the middle, do not chase and rotate the nucleus, and it's possible. Now is the time to bring that communication business, detach the epinucleus a little bit so that the fluid is equally distributed in both compartments, and the bottle height should not be very high, and flow rate modest, 20 cc per minute, maybe 25, but not very high. You want a good control on it, and then you can avoid that thing happening there. Now at this time, if it doesn't come, it's quite okay to do subcapsular hydrodissection because fluid won't be trapped there. So don't make an issue of these if it doesn't come. Always do subcapsular hydrodissection, but remember, inject viscoat or something like that. And with the bimanual, it's not difficult to produce that total removal of the cortex here. Once again, swap the instruments there and perform that. Now, the best part of these principles that we just went through is that you can deal with any degree of density or any integrity of the posterior capsule. These are the examples where these denser fragments were fed into the phaco tip without rotating, and bevel, notice it's facing down. I'm not worried about the surge because of the appropriate flow rate and also the machinery that we have. So 20 cc flow rate will not attract the posterior capsule. Once again, another example of these denser fragments. With the flex, it's a little easier because they are already pre-grooved to some extent, but even if they are not, inside-out delineation will be enough, and you can see these denser fragments coming to the phaco tip and being fed well with 40 IOP. That means about 52 centimeter bottle height and 18 to 20 cc per minute flow rate, and appropriate power, which is here at about 40 or 50, and using an interrupted, which is my personal choice, but whatever mode you want, and take this out at your time. Notice how slowly that we are doing. We need to be very patient about it, be conscious of the chamber stability, and if you can lower the flow rate and vacuum if you are scared when the posterior capsule keeps glaring at you. So take your time, but make sure that you remove it at the right plane. I'm keeping my bevel facing sideways and also to the posterior capsule because I want to avoid the impact on the endothelium. So this is one more very good case, bilateral posterior polar cataract with both eyes pre-existing defect. And that's where the flex or the intraoperative OCT or imaging technology will help. We could recognize, we could see that in the slit lamp also, but sometimes with the density, the cataract, we may not be able to visualize. So all this imaging technology will make you prepared, and you will anticipate appropriate thing. And this is on the table, the same eye, you can see the posterior capsule defect already present in front, behind the posterior capsule, posterior polar defect. So once again, if you do not have a flex, doesn't matter. You can carry out very controlled inside-out delineation or whatever delineation you want to take, but make sure that you protect the exposed vitreous phase. The aim is to prevent the vitreous prolapse here, and therefore mechanical cushion effect of a decent depth is important. You can do that equally well with manual techniques of delineation, but flex will make it a little easier. Now, once again, I am trying to remove that nucleus bottom part, and notice my IOP is 20, that means 30 centimeter bottle height, 20 millimeter mercury pressure, and flow rate is 16 cc per minute. Sometimes I go to 12 cc per minute with phaco probe. You can't go lower than 12 cc, but you use as low parameters as you can, and detach it and establish the communication so that the fluid will cover it. Now I raise the bottle height from 20 to 30, and sometimes I go to 40, because now I have a fluid pressure sitting on that exposed vitreous. I'm not worried about unequal hydraulic pressure because it's all communicated well. And that posterior polar stuff is coming out, as you can see. And bimanual technique, once again, really is a great help maintaining the contour and not utilizing the valve effect of the main incision. So that's protected. So far we are lucky, but anytime vitreous can prolapse. So because of the, notice the IOP has gone down to 50, that is 64 centimeter bottle height, because now I want a good pressure on the exposed vitreous face, and I was lucky that it went on okay. Now, I would prefer a 3-piece IOL when the capsule is open, posterior capsule is open, and you can utilize a 3-piece, sometimes capturing it through this, or putting the haptic in the ciliary sulcus and having optic at a different plane. So you can do that. I'm utilizing that pre-existing defect as to capture. So I'm pressing the optic, nudging it opposite direction, and then pressing it posteriorly. So the optic has gone behind the posterior capsule, in front of the antivitreous face, and the haptics are at the ciliary sulcus. So you can utilize various combinations, but make sure whenever the posterior capsule ruptures or is open, at the end of the surgery, I've taken the suture, the main incision, to make sure, is there any vitreous? Well, I didn't have a vitreous, but I had kept vitractor open in anticipation. I didn't have to use it. So this was an opportunity for me to use, to remove the, aspirate the viscoelastic. There was no vitreous. Just because I had vitrectomy opened up, I had to justify its use. This is what it looked later on down the line, post-operatively, and monitor peripheral retina and so on, and monitor the stability, whatever imaging you have. And lastly, the pearl 6 is the most important pearl. Pre-operatively, please tell the patient, not only the patient, but bring the family members. One second counseling, we do 2 counseling settings, one with the patient and whoever has come, and we say, whoever else is with you, bring them next time, and tell them all the eventuality. But finally, remember, posterior polar cataract is not over until you remove the speculum. So this is an example. My nurses were packing up, and they were very happy that I could do posterior polar without any problem. And look what happened. If you are not very careful, or if you are very aggressive, this can happen. Now, we had a dilemma what to do. We decided not to do anything and leave it because there was no vitreous prolapse. And it worked well, luckily for us. But the point is that posterior polar is not over until it's really over. So to sum up, these are the pearls I learned from the stalwarts sitting on the dais, Dr. Osher and many others. So keep in mind, and good luck when you have this kind of cases next time. Thank you so very much.
Thank you, Abhay, such a wonderful teaching on the posterior polar cataract. And the videos were so clear, so transparent to see every bit of fibers also. And your teaching has been, I think, it has gone to everybody to how to perform effective phaco in these cases of posterior polar without the capsular opening or a capsular opening or intraop difficulties. Beautifully shown. Thank you.